was a med student, I thought that residency would be one of the darkest times of my life. And right now, I can tell you that it's actually the opposite, at least in family medicine. Hey, welcome back to the channel. I'm Dr. Thiago Luzvargi. Finally, and sorry I haven't made a video in so long related to medical school and residency. I have some notes. I just want to go over a little bit about how the past 5 months, the first 5 months of residency have been, to let you know, one, what goes behind the scenes in residency, and two, for those of you med students preparing for interviews, if you want to apply to U of T program and to the Barry campus or the site, that's where I'm at. You have a little bit of a better idea of what to expect and the pros and cons, okay? So first of all, starting off in July, it was very overwhelming trying to figure out the logistics of the EMR, electronic medical record. And that is Acuro for family medicine and then Meditech in the hospital. I was trained in, I think, PS Suites in Ottawa and Epic. And so learning how to open the chart, write notes, how to prescribe medication, how to order labs, all that in the beginning becomes very challenging. It's a steep learning curve, or not steep learning curve. It actually takes a little bit to learn. And then you just get it through repetition. The other thing is with Acuro or being a family doctor is that we have to be on top of prescription renewals. And so we're responsible for 200 patients, give or take, where I have to review the medications, keep renewing them, review consult notes, imaging reports, blood work, and so on, and that I have to review, renew those medications. If I don't know the answer, then I either look it up on a website or talk to a supervisor and try to figure out, should I bring this patient in for a follow-up before I renew this medication, or is this a safe medication just to keep on renewing? One thing that I want to add on to that is that because I am a family doctor and responsible for those prescription renewals, sometimes on my day off, I feel the need to go on and make sure that there aren't any prescription renewals I haven't missed. Sometimes patients go on a break and they want an upfront prescription renewal of all their medications, and if I don't get that in time, one, I feel bad. Two, we have backups where our doctor of the day will catch that, but it is kind of like extra homework to do to stay on top of things. The next point that I want to share is that being a resident definitely feels more like a job rather than studying or being a medical student. The nice thing is that I am responsible for my patients, coming up with a diagnosis, the plan, the management, but I get to review that with my supervisors. They get to tweak, give me feedback, say you're wrong or you're right, continue doing what you're doing, and having that safety net is nice. But finally, after 4 years of undergrad, 4 years of medical school, I do actually feel a greater sense of responsibility over my patients, and therefore, because there's that sense of responsibility, I'm much more invested in my learning, invested in helping those patients, and just growing overall as a person and a doctor, because I definitely don't want to let my patients down. And that has happened and will continue to happen because I'm not perfect, but I continue to work on patching up those mistakes so I can improve. One of the things that I would say felt really weird at the beginning is being called Dr. Luzvargi for the first time, and even to this day, sometimes it catches me off guard. I'm introducing myself to patients. I'm like, hey, I'm Dr. Thiago Luzvargi, family medicine resident, and I often catch myself slightly give myself a smirk or a smile because on those hard days, I can't believe it that I'm actually a doctor after all that hard work. And every now and then, I am very grateful for this opportunity to be able to be in this area, this health job, and to be able to help patients the way that we do. It's not easy. There's a lot of challenging days. But that was one thing that at the beginning of residency feels so weird. It feels like, I don't know, that's not me. I'm not a doctor. I'm just a med student. I have no idea what I'm doing still. And I think that feeling, that imposter syndrome, that feeling of, I'm not sure what to do. I don't even know what you have. I have to kind of look it up. I have to, it's a normal part of learning for any career. And it's one feeling that you have to get comfortable with because it's going to continue for the rest of your life. There's always going to be new things coming up, new medications, new treatments, part of the process. So going off of that imposter syndrome early on in like your first month or two, actually at the beginning of every specialty rotation, your block, you operate like a med student where you're just kind of observing, you know what to do, but you don't have that experience to have the confidence to take action. But as you get experience, you start to commit to diagnosis, you start to commit to your management plan, and that is extremely fulfilling when you present to a preceptor and they're like, yep, I agree with you, let's do that. And you end up getting the diagnosis right, the right test, the right treatment, and that is extremely fulfilling. And so that is the natural process or the progress of you or of me as a resident. Is you start off very weak and confused, and you start to build those steps and build the skills to give you the confidence to commit to then helping people properly. And it's just another thing that you got to get used to. Initially, some of the things that I would think when I review with my supervisor or I'm working with an emerge doc is like, how in the world do these people do this job? Because there is such a variety of diagnoses, such a variety of treatments and investigations. I still feel very out of place whenever we start to dive deep into one condition, because I kind of know about a little bit of every condition that I've heard of. But when you start diving deep into the whys, the pathologies, the etiologies, why certain things happen, it just blows my mind when I'm talking to a family doctor that's been working for 10, 20, 30 years, and they just know the ins and outs, and it's amazing and extremely intimidating that patients, or the expectation is that I should know that level of knowledge. And that's when you just have to reset the expectations, take a step back and say, it's the first year of being a resident, and I just have to learn the basics first, and then slowly I can pile on more and more information. With that, the thoughts come, am I really good enough? And the answer is yes, but there's still a lot of work to do. There have been a lot of questions that patients ask, and I'm like, I'm sorry, I don't know exactly what you have, but I'll look into it. I'll review with my supervisor. We'll come up with a plan, and hopefully we'll start at step 1, and we'll pivot depending on what the results are. And so we always don't feel adequate. I don't always feel adequate for what I have to do, but it is the beginning. And the other thing is I have 200 plus or minus some patients that I'm responsible for, which is crazy when you think about it. It's not a lot relative to a full workload, but I have to stay on top of 200 patients while being in my specialty rotations. And we'll get to how my rotations are broken up too. Right. So far, right now, today is December 9th, 2023. I'm about 5 months in, and these are the just the rotations that I've done. I've done 4 weeks in emerge, 4 weeks in mental health, 4 weeks in general surgery, 8 weeks in obstetrics and gynecology, and then I'm almost done 4 weeks of our musculoskeletal system, MSK unit. And towards the end of my 6th block, entering the 7th, which is going to be my elective. And the way our schedule is structured is that every week I have about 2 to 3 half days of family clinic. So I have to be at our family clinic seeing first it starts off with like 3 patients, and then it builds up more per half day. And I'm going to show you my schedule soon later on in this video. So when we're not in the clinic, at family medicine clinic, we're doing our specialty rotation. So I'd be doing like an emerge shift in the afternoon, or I would be doing some surgery shift the next day, like a full day. Right now on my MSK unit, I'll do like a morning of chronic pain, and then I'll do an afternoon of family medicine. So that's roughly what it looks like. Some of the other things that we have to do objectively as residents is we have a lot of mandatory modules, so we have to fit that into our schedule every now and then, stay on top of it. We have a quality improvement project to do by the end of the year where you work as a team, and then we have to do at least 6 walk-in shifts throughout the year as well. And so that is about from 5 p.m. to 8 p.m. And I did my first shift yesterday, and it was actually really fun. I got to see 5 patients, a variety of conditions, and it's nice and fast. And that's where you really get to learn and practice those the bread and butter of family medicine. The next thing I want to share is the salary. So right now, you can look this up online. We get paid as a first-year resident $67,000 plus call stipend. So if we work late to 11 p.m. or to 1 a.m. or work on a weekend, we get paid for that. So plus or minus a couple hundred or $1,000 per month, probably 100. That's roughly how much we make. And then the nice thing about family medicine is we have a lot of time on our easier rotations to do a lot of hobbies. So in the summer, I went fishing, paddle boarding, boating with family, went to weddings, spent lots of dinners and holiday times with family. Now that I'm at home in Barrie, near Jess's family and my family as well, I've been recording some podcasts, and I have time to listen to podcasts on the way to and from work. So family medicine has been really nice, and that way it's a lot more chill. I don't have to wake up at like 5 a.m. and be rounding on general surgery patients at 6 a.m. like I did in medical school. All right, so I have the schedule here. You should see it on the screen somewhere. I'm going to go through each rotation so you have an idea of how our schedule is set up. So for emergency medicine rotation, that was July, and I had a total of about 10 to 12 shifts in a month. And then when I'm not working, I actually have the day off, or I have family clinic. So there's academic half days are every Wednesday morning for first year, and it's afternoons sometimes for second years. And so on a Wednesday, we do our lectures, we do some learning, and then that afternoon I had family or emergency medicine for 8 hours. So it's an 8-hour shift, total of 12 hours. The really nice thing about emergency medicine is that variety. You're one-on-one with the preceptors, so you get to know the supervisors, the doctors really well, which really helps when you're in other specialties and you're getting consulted by them, so you know them and have that relationship established. So you can see that in a week there, maybe the third week of July, I had 3 half days of family medicine. It says FMTU, Family Medicine Teaching Unit. I had a call on Sunday, and I had to work late from 5 to 11 or 5 to 1 on that Wednesday. And so those are my shifts there. So moving on to mental health rotation. So this is going to be a variety of psychiatry, working with adult psychiatrists, pediatric psychiatrists, methadone clinic for addictions medicine, and working at a kind of like a outpatient clinic for schizophrenia and things like that. So here you can see that in the morning for Thursday, August 3rd, I was at the methadone clinic in the morning, and then later in the afternoon I was at the early psychosis intervention. We have a couple of sessions with just online where we learned about the different health support networks and resources that we have in the community. That's the CWMS. On August 2nd, we worked at Youth Haven to help with kids or teenagers that have a challenging life but don't have a place really to live or don't have family doctors. We pop in there for the morning and help them out with diagnosis, treatment plans, etc. And then so on. So we get a little bit of experience with inpatient wards with adults and also children. Now the thing about this type of longitudinal program is that and it's different from block-based, is that every day is a little bit different, right? And it's just giving you a little bit of a taste, a flavor of what this specialty could be, so that you as a family doc have an idea of what's happening when you refer people or when a patient comes in and they tell you, I've been to inpatient program at RVH. And so the difference is that in a block-based program, you're fully immersed in the specialty for 4 weeks. Like, you're rounding on these patients, you're getting to know them a little bit better, you have a better sense of maybe managing them and doing follow-up investigations. Whereas here, because the hospital we work at is community based, or is basically fully ran by staff, they do not depend on residents. We get to pop in, help, see, be part of the process, get pulled, and we get placed in another clinic. And so that there's pros and cons. The nice thing is that the cognitive load isn't really there, where for example, if you're in inpatient medicine for internal medicine, you're not in the ward every day for 4 weeks. You're in the ward for a couple days out of the week, And then you also shadow different subspecialists within internal medicine. That was mental health, so that's about 8 hours per day, and you have about 8 to 10 shifts or days where you work with family medicine between, and we discussed that. All right, surgery rotation. This is August 28th, September 24th. Again, each day is kind of about 8 hours per day, 11 days doing surgery, and you get to see a variety of things such as appies, choles, bowel obstructions, hernias, mastectomies, clinics. So we see lumps, bumps, hemorrhoids, all that kind of stuff. And you're on call 4 days until 11 p.m. So it's not a 24-hour call. Most specialties here, it's just a call till 11 p.m. The only rotation where it's a 24-hour call is OBGYN. And it's turned out it's not as bad as I thought it would. It's actually kind of enjoyable. All right, so this surgery rotation, we have skin biopsy clinic every Wednesday, so that's really nice. Get to see a variety of skin cancers, biopsies, suturing. That helped a lot. And then, like I said, there's acute care service, ACS. We're in a surgical treatment clinic, helping suture and do a whole bunch of things. And you see that we also have a sim lab on September 18th, where we ran some trauma codes. So we do a lot of sims, part of our academic half day. And it was really good for learning. So that's surgery. Pretty nice. You're not rounding every day, so there's physician assistants. There's a lot of physician assistants, and without them work can be a lot more challenging, but they basically function as the senior residents. Their words, not mine, but it's true. They do a lot of the rounding and manage the patients in the ward and help do consults. And then when we residents are with them, we help take off some of that load by seeing the consults first and helping in the OR. Next rotation is OBGYN. So typically we're working about 9 hours per shift. There's about 11 shifts, 11 days we're on it. And we see a variety of colposcopy clinics, doing like pap tests and things like that. Well baby clinics. We're working on the birthing unit, and we're seeing vaginal delivery, C-sections. We're helping with triage and the ER consults as well. And we have 3 to 4 days on call. Those are 24 hours. And like I said, the PA does the rounding, but if it's slow, then I would help her out. And overall, I enjoyed working with everybody for all of these rotations. The first schedule that you see there shows that the first 2 weeks is colposcopy. So you're getting a lot of experience doing these pap tests, swabs, using the speculum, which can be very challenging and very challenging to find the cervix. So it was nice to get that experience over and over with a surgeon, a doctor telling you, different techniques to help with that. And then from week 3 onwards, it's basically just the birthing unit. Notice that in week 1 and 3, there's prenatal office and well baby. So there you get to see patients that are leading up to pregnancy. So you work on a little bit of that counseling, prenatal counseling, and also postnatally, after delivery, you get to do a little bit of like lactation counseling, seeing how they're feeding, any side effects. And so right now we are kind of advocating to increase those clinic times, because those are going to be extremely helpful as family doctors versus just being on a birthing unit where not everybody's going to want to be delivering babies. All right, second month, same thing, a little bit more consistency. So I had calls every Monday there, and then a call on Saturday, October 28th. But you get into the rhythm, the doctors, the triage process. And so that's where it becomes a little bit more enjoyable, because you kind of know what to expect and the plan. And OB was really nice, being able to catch those babies, see the parents be happy. And overall, that is what makes it really rewarding. All right, last one. If you're stuck around here, you're committed. Enjoy it. Thank you. Here's our MSK unit, where you get to see I work with an orthopedic surgeon in the beginning. We get to assess knees and hips for preoperatively to see if they qualify for surgery, or do knee injections for arthritis. We have FMTU in there. Pain clinic, where watching one of the pain docs, the anesthesiologist, do these nerve ablations or nerve blocks. We have fracture clinics, so we see a lot of follow-up for patients who present to the emerge with a broken bone, and then they come to fracture clinic for that. Work with physiatry to learn about electrical conduction studies. Work with sports medicine doctors and a chiropractor to see what's it like being a sports med doc, and how can we understand a little bit more about chiropractor and other kind of allied specialties that we can refer to and when that would be beneficial. And so in this block, we work with orthopedic surgeons, sports meds, chiro, plastic surgeons, that's hand clinic, seeing broken fingers, torn ligaments, fingers that got cut, and so we get to see a variety, lipomas or skin cancer removals, so that's really enjoyable as well, and so on. So overall, I'm in block 6, 5 months in, and residency has been really nice, really fun so far. I'm sure that if I had to sit down, I could complain a bit, but everybody complain about a lot because there are challenges. But relative to my thoughts, when I was first and second year med student, just a med student in general, I thought residency would be extremely brutal and challenging. And it's been the opposite. It has been challenging, but it's been a lot more rewarding, a lot more enjoyable and fulfilling because of my colleagues, the residents I work with, the supervisors I've been working with, and I think the program in Barrie has overall been amazing, and I've been enjoying every step of the way. Now, here are some lessons that I just want to leave you with. It's really important to get good at getting better. So try to always improve in your communication skills, in differentials and treatment and management, all that. It's really important to have this mindset of constantly improving. And that comes with the ability to embrace failures and being willing to admit when you're wrong. And that comes in handy when you're reviewing with preceptors and when they ask you, did you ask this? You gotta admit, like, I didn't cross my mind, and that's a learning opportunity so that you can continue to improve. If you improve a little bit each day, then by the end of the year, you're a whole new person. You have a whole new skill set. And then it's really important to ask questions. If you don't know something, don't just assume you'll figure out in the future. Just ask those questions in the moment while that information is sticking in your brain so that it sticks, and next time you review it, it's gonna be in your brain and you're gonna understand it a lot better. One thing that I wanted to share is a really cool opportunity that I've had recently is going with one of our sports medicine doctors to the ringside with the Barrie Colts, one of the OHL teams that we have here. And so that's a really neat experience that we get as a family doctor resident, is being able to see a variety of things and see, can we envision ourselves doing this kind of medicine? So far, been really enjoying my MSK unit, doing these injections, and going to a hockey game. And so overall, really enjoyed it. If you have any questions, please drop them in the comments down below. Follow me on Instagram. And if you want to see other videos like this, comment them and I'll try to make those videos for you. Take care.